Hey Squishies! Welcome to part 2 of my presentation on the gender dysphoria diagnosis. In this part, I'll be talking about treatment for gender dysphoria, as well as some recent-ish developments in neuropsychology, which may shed light on both how gender forms during child development and in what causes gender dysphoria. I will also then segue into discussion of kind of the controversy around the gender dysphoria diagnosis in the DSM, and conclude with some thoughts on what might be done to improve the situation. So, in treating gender dysphoria, it is important to understand that gender identity, here meaning kind of the combination of core gender and conscious gender, is sometimes fluid, but it's also very stable. Gender fluidity exists, that's what I mean by saying that it's fluid, both in the sense that a person can have one gender when they're 10 and another gender when they're 40. This is a known phenomenon which people have expressed accords to their experience, and therefore any theories we construct must account for it. Second, I discussed in part 1 about gender fluidity as an identity in itself. A gender fluid person might cycle through genders quite a bit faster than that, but in both cases, the person's gender changes over time. However, it's very stable in the sense that these are internally driven changes. Whatever is causing a gender fluid person's gender to change, whether that happens over a period of decades or the course of a single week, it is an internal process. Gender is very resistant to external pressure to change. For example, there are historically and unfortunately currently attempts to change people's gender through what's referred to as therapy. I say referred to as because, first, it doesn't work at achieving what it sets out to do. You can't change a person's core identity through any kind of therapeutic intervention, or frankly, any kind of intervention that is known to human science. It simply cannot be done. You can alter someone's gender expression, but it does not alter their gender identity. And the way we know that is that it is accompanied, if the person's gender identity was in fact changed to match their assigned gender at birth, you would see a decrease in gender dysphoria symptoms, but you do not. These so-called therapies increase the negative symptoms of gender dysphoria, especially suicidality. People who have been through so-called conversion therapy have noticeably higher suicide rates than trans people in general, and trans people in general already have very high suicide rates. It's actually pretty predictable for what I was saying about protective factors in the first part. Being accepted as your gender reduces suicidality. Having your gender so rejected that you're expected to reject it yourself increases suicidality. Because of these profoundly negative outcomes with no benefit whatsoever, these therapies are increasingly being banned in a growing number of jurisdictions, as honestly they really should be, because this is not a therapy. This is trying to change someone by making them suffer. The term for that is torture. And frankly, it really cannot be done. Even extensive brain damage cannot alter a person's gender identity. A 2019 review of the literature found that there had, in the entire medical literature, been only ever one instance of a researcher reporting a change in gender identity in a patient resulting from brain damage. And this single 2015 report was actually really suspect for a number of reasons, the most important of which is that the reported change in gender identity happened years after the damage. If the damage had caused the change in gender identity, you would expect it to have happened when the damage did. Kind of what's implied by the total absence of brain damage changing someone's gender identity is most likely one of two things. Either gender is a distributed function across a significant portion of the brain that involves a lot of different parts of the brain, and as a result, all of that has to be, or most of it has to be damaged in order to substantially, detectably alter someone's gender, with the result that the level of brain damage you're talking about is so great that you've already reached the point where the person cannot communicate or possibly is even dead. Either that, or it's located in such a deep or critical area of the brain that you have the exact same problem. You can't get to it to damage it without doing so much other damage that the person is either unable to communicate their identity or dead or vegetative or whatever. The point is, it suggests that gender is either involves a great deal of the brain or is very deep in the brain, and regardless, it suggests just how hard it is for external factors to alter gender. The only effective treatment for gender dysphoria, the only thing that relieves the distress at all, is transition, which is to say, making lifestyle and physical changes, or I should say, that allow the person to live more fully as their core gender. This can involve any or all of the following, and this is a list of examples. This is not exhaustive. It could involve what's called social transition, which is changing the gender expression markers, wearing clothing more typical of the core gender instead of the assigned gender, learning to speak in a manner more typical of the core gender, coming out in this context, meaning telling people your true gender and your core gender, and possibly pronouns and a new name that is more associated with your core gender. And it could involve legal changes, seeking legal recognition of a change of name or a change of legal sex or gender. Hormonal changes, hormonal treatments include what are called MTF, standing for male to female, and FTM, standing for female to male. These are somewhat unfortunate because, again, they imply that the person is changing from one thing to another, which is not what transition is. It's not changing who you are, it's changing how you live and how you experience yourself and others experience you. But there's two sets of treatments. For people assigned male at birth, typically treatments will involve a class of drugs called anti-androgens, which suppress testosterone production, and estrogen, which is the primary hormone that triggers like typical female puberty and is also typically common in post-pubescent women. In some cases, this is still somewhat more experimental, but progesterone can also be prescribed. Progesterone and estrogen kind of make up the two sides of the hormonal cycle in a quote-unquote typical female body. And there's some research to suggest that you get better results by actually simulating that cycle with medications. I say simulating, but really you're just doing the cycle. It's just coming from a medications rather than the glands, but it's the same chemicals. In people assigned female at birth, you can administer testosterone. There's no need for an estrogen suppressant or a progesterone suppressant because testosterone already has those functions. Essentially what these do is they trigger puberty. In a assigned male at birth patient, they will cause changes in fat distribution, they'll cause breast growth, changes in skin texture, many of the typical changes of a quote-unquote typical female puberty. If the patient has not previously gone through puberty, the changes will in fact, I don't know why my slides just collapsed like that. If, as I was saying, the person has not previously gone through puberty, the changes will in fact be almost all of the changes of quote-unquote typical female puberty, including bone structure changes. If they have already been through puberty, then those the bone structure changes from the first time through are irreversible, and so that won't occur. With testosterone, in addition, well, I'll get to that. With testosterone, what happens is some elements of typical male puberty, growth of body and facial hair, and deepening of the voice being the most obvious external ones. Now, again, if the person has not previously gone through puberty, then those are the changes that they will go through. If they have previously gone through puberty, then the bone structure changes are irreversible. And in addition, the growth of breasts can only be reversed surgically. So having gone through puberty before means that more intervention is needed, and in some cases, currently medicine can't do it. Modern medicine cannot change your bone structure in order to achieve a quote-unquote typical male body or typical female body. This is why one of the reasons that puberty blockers are important. The other reason is that, as I'll get to in discussing theories of causes, puberty is very frequently intensely traumatic for trans people. It is a massive increase in gender dysphoria and sometimes the origin of the sensation of gender dysphoria. And the effects of it are frequently, some of the effects of it are irreversible without surgery, and some of the effects of it are irreversible, period. So puberty blockers are very important when someone is aware of being trans at a young age. Now, contrary to what you may have heard in the media, it is simply untrue that puberty blockers are experimental. They have been in use for decades. It is also untrue that they might have unknown long-term effects. Again, they've been in use for decades. If they had long-term effects like that, we would know by now. In actuality, the risk of long-term effects is extremely low and comparable to other drugs that are given to children all the time for far less serious things. Typically, if someone is on puberty blockers, all that does is delay puberty. It puts a pause button on it. If they go off the puberty blockers without taking any of the other hormones on this list, then puberty will start as normal for someone of their assigned gender at birth, and it will proceed as normal, and there will be no long-term difference from if it had started at the age that puberty blockers were administered, which is they have to be administered pretty much at the point where puberty starts. They're not given before it. So if the person decides that they do want to transition, which is really what it's about, is a small child cannot give informed consent to the kinds of long-term physical changes that being on hormones for a period of years can cause. So the puberty blockers are used to pause the child's puberty, avoid damage from it, until the child is old enough to be able to make that decision for themselves. And then they can say either, I want to go off the puberty blockers and have puberty as normal, just a couple years later, which happens sometimes naturally, or they can say, no, I do want to go on the hormones and start getting the hormones and not suffer the ill effects and the irreversible effects of having gone through the wrong puberty. Quite simply, the opposition to them is purely political. It has no scientific or medical basis, and it is going to cause needless suffering to children in the name of protecting imaginary children from an imaginary problem. Anyway, in terms of surgical interventions, people who don't know about what transition typically consists of will sometimes ask a trans person, have you had the surgery? Which, first of all, is generally rude. The circumstances under which it's okay to ask a person about their genitals are very limited. And unless you are in those circumstances, it is not okay to ask if someone has had surgery on their genitals either. In addition, that's not the only surgery. There is actually, as you can see, a lengthy list of possible surgeries that might be involved in transition or might not. It is up to the individual which of these treatments they want or need. Anyway, common surgical treatments involved in transition include phalloplasty, which is the conversion of genital tissue into a penis, vaginoplasty, which is the conversion of genital tissue into a vagina, orchiectomy, which is removal of the testes. This has the additional effect of negating the need for taking anti-androgens, which is nice because their side effects, while not serious, are unpleasant. There's also two forms of what's called mammoplasty. Reduction mammoplasty is reduction in the size of the breasts or outright removal of the breasts. And augmentation mammoplasty is surgery to increase the size of the breasts. However, for someone who is taking hormonal transition treatments, estrogen may have the effect of, well, it does have the effect of causing breast growth, and depending on the individual, there may or may not be a need for additional surgical intervention. Speaking personally and somewhat inappropriately because it's late, these are all real. This is estrogen, not surgery. Estrogen and genetics, I should say. Also quite common is some form or another of facial reconstruction surgery to correct the impact of going through the wrong puberty initially on bone structure in the face. Two more that are relatively uncommon but are out there are what's called Wendler glottoplasty and tracheal shave. These reverse the effects of quote-unquote male puberty on the vocal cords and the Adam's apple. Finally, there are outpatient procedures, and these mostly exist to reverse the effects of testosterone on body hair and head hair. Hair transplantation is a treatment for baldness. Electrolysis and laser hair removal are treatments to reduce or eliminate body hair. I should note that these are ordered in the order of, roughly order of expense. Electrolysis is bloody expensive. I have done the research. It would in fact be cheaper for me to get surgery than to get all my body hair removed. To get multiple surgeries than to get all my body hair removed. Electrolysis in particular is very labor intensive and expensive and time consuming. Finally, does therapy and psychiatric medication have a role in treating gender dysphoria? Sort of. So therapy can help with adjusting to the changes that come in one's life as one is transitioning. It can help with coping with feelings of loss around, for example, experiences that were missed because one didn't transition earlier. It can help with kind of unlearning maladaptive coping strategies that a person may have developed to try to handle their gender dysphoria before they were able to transition. However, it cannot treat gender dysphoria itself. It can also help with some of the comorbid conditions. Psychiatric medications, similarly, can help with the comorbid conditions. But in the absence of transition, neither of these things does anything for gender dysphoria. All right. So it's worth asking, where does gender dysphoria come from? For that matter, what causes it? For that matter, what causes being trans? Why are some people trans and some not? And to answer that, we kind of need to ask the question, what causes gender? Where does gender come from and how does it form? And the answer is no one knows. But there's some relatively recent developments in neuropsychology which may point in the direction of a possible explanation for all of these things, and in the process also help explain some of the more mysterious things about both gender dysphoria and about the existence of gender variance. Most of the next 3 slides is kind of a summary of the first 2 chapters of the book Theorizing Transgender Identity for Clinical Practice by S.J. Langer. If you are at all interested in this general topic or in specifically working in a clinical setting with trans people and finding ways to do that without pathologizing transness, I highly recommend that book. It's very dense, especially the first couple of chapters, but it's very good. So, to understand this theory, which has to do with what's called Enteroception and a brain function called body maps, we first need to turn to some basic biology. And I mean actual basic biology, real science, as opposed to the approximation that people get taught in 8th grade and think is how biology works. Although this is actually a relatively simple concept, so this actually is taught moderately accurately in middle and high schools, and sometimes. And that is the concept of homeostasis. So homeostasis is the process by which an organism maintains a stable, optimal internal environment. Every organism has all kinds of chemical and, in many cases, for multicellular organisms, physical processes happening inside of it. And those processes need a stable environment with particular properties in order to proceed in a way that contributes to the organism's health and survival. And to make that happen, the organism maintains homeostasis. So, for example, maintaining a temperature at which those reactions can occur, maintaining the right balances of nutrients, all of that kind of stuff falls under homeostasis. Now, every organism has processes of homeostasis. What those processes actually are, it varies quite a bit. It's very different for a bacterium compared to, say, a giant redwood compared to, say, an elephant. Now, allostasis is the process by which an organism restores itself to homeostasis after homeostasis has been lost. Allostasis is a more active process and takes more energy. So it is better for the organism to stay in homeostasis, but it's not always possible. And if something happens that causes the organism to lose homeostasis, it has to take action to restore itself to that balance. And that action of returning itself to balance is allostasis. If allostasis doesn't or can't occur, then the organism starts to suffer negative consequences and can get sick and die. Allostatic stress or allostatic load is the increased burden on an organism's function represented by allostasis. As I said, it takes more energy to achieve balance than to stay in it. So in biology, this is typically called allostatic load and thought of in terms of energy. In psychology, it's talked about in terms of stress, because there are psychological impacts of this, as we're going to be discussing. Interoception is a function of the human nervous system. It's a function of many organisms' nervous systems, actually, but it's been heavily studied in the human nervous system, that monitors the interior of your body. And so one of its most important functions is to monitor homeostasis and trigger allostasis as needed. It is not the only thing that will trigger an allostatic response. There are many things that happen at the biochemical level rather than the body system level to trigger allostasis in kind of a local way within a part of the body. There's also the endocrine system has functions that will trigger allostatic responses, but the interoception is kind of the body-wide responses. It's things that require a little more coordination and what we would more typically think of as an action of the organism as opposed to an action of certain tissues. Now, the interoceptive system, as it turns out, gathers significantly more information than exteroception, which is what we normally think of as the senses. It's the part of the nervous system that, and of the perceptual systems that gathers information about the environment around us. There's also a third category called proprioception, which is gathers information about your position and orientation in space. So exteroception is the environment around you, proprioception is kind of your place in that environment, and interoception is the environment within you. Proprioception is how you can do this. You know where your arm is, as long as your proprioceptive system is functioning. And so you can put it in a very specific place relative to another part of your body. So anyway, the amount of information that the interoceptive system gathers is more than the brain could actually handle processing on a regular basis. So it needs to take a shortcut. And the shortcut it uses is something that neuroscientists have theorized as a brain map, or a body map, rather. Now, the term body map is sometimes used to refer to another older concept called the sensory homunculus, which is kind of a map of how the senses and different body parts register in different parts of the brain. That is referring to exteroception. The body maps we're talking about have to do with interoception. And the way they appear to work, according to research in the last, not very many years, so like any more recent research, this is subject to change. But the way they appear to work is that they function as a set of what are called priors. Basically, a checklist of signals that your brain is expecting to receive from the interoceptive system. And as long as it can check everything off as matching what it expects it to be, it just stops there. It does no more processing of that information. So as long as everything is as expected, your brain doesn't get involved very much at all, except for this one small area. Interestingly, priors appear to be more or less hardwired at birth. I'll talk a little bit about one piece of evidence we have in that direction, but it does seem to be the case that your priors vary from very difficult to change in response to environmental factors to impossible to change in response to environmental factors. The priors, and you do appear to be born with them. They probably form well before birth, actually. That said, it does happen that interoceptive signals don't always match your priors. And when that happens, the brain has to get involved in an allostatic response. So you sort of have three levels of allostatic response. First of all, there are automatic responses. These involve little brain activity, sometimes none at all. Again, as I said, sometimes things happen biochemically, or the endocrine system handles it with little or no nervous system involvement. But an example of an automatic response is your body temperature is getting too high, you are no longer at the ideal stable body temperature, so you start sweating to shed excess heat. It's purely automatic. It doesn't even enter subconscious processing. Your brain is barely doing anything with it at all, except potentially the exteroceptive system may be detecting the sweat on your skin. The next level up is allostatic emotion. If there's a reasonably sized discrepancy, your subconscious brain processing becomes active, and you experience an emotional response. This is some interesting stuff that's been done with electrodes in people's guts. I have no idea how they got volunteers to do this, but somehow they did. They put electrodes in people's guts and slowly turned them up, and found that there was a certain level where the person was not aware of any sensation, but became irritable in response. What appears to be happening is that your brain is using less energy-intensive forms of processing to generate emotions, which will get you to stop doing what you're doing, like lethargy, irritability, that kind of thing. Emotions that get you to change your behavior, and hopefully that will cause you to stop doing whatever it is you were doing that was disrupting homeostasis. For example, using your body temperature is getting too high example, maybe you start feeling cranky, so you go back inside and you're no longer in the hot sun. Just as kind of a random example. Finally, with the most extreme discrepancies between the interoceptive signals and the brain, you get allostatic sensation, which is a conscious awareness that something is wrong in your body. Some examples of allostatic sensation that can happen here: hunger, thirst, craving a specific food or a specific activity, feeling that you need to use the bathroom, feeling too hot, feeling too cold. Pain can be a response, although pain can also be triggered by the exteroceptive system. All of these can go off, but only for the higher level of discrepancy between the interoceptive system and the priors. And again, the priors change very little to not at all during the course of your life. It's the signals from your body that change, and these responses happen when they don't match. Now, it is worth noting the higher two levels of allostatic response are the ones that involve emotions and sensations. Those emotions and sensations are unpleasant ones. Always. Allostasis never feels good. It always feels bad. And it always creates a pressure to change your behavior. It puts a psychological stress on you that you feel a need to find some action you can take to relieve this stress, because that returns you to homeostasis. I mean, you aren't necessarily consciously thinking, I need to return to homeostasis, obviously, but that is kind of the origin of this system, and what its function is for you to take action to relieve the stress so that you can go back to homeostasis and not get sick and die. So what does any of this have to do with gender? Well, this is where Langer pulls together these kind of different findings and asks the question, and talks about, okay, part of your variance in body maps is going to have to be kind of gendered characteristics. Physical sex, primary and secondary sexual characteristics, for example, are going to differ between individuals, and your body map has to be prepared for that difference. It has to have priors that account for that difference so that it doesn't incorrectly flag interoceptive signals from those body parts as being a problem. But there are other subtler differences that have to be accounted for by interoception. For example, I mentioned changes in how fat is distributed in the body in response to sex hormones. There are a number of other different kind of subtler responses to sex hormones that affect things that are not kind of anatomically detectable in the way that primary and secondary sex characteristics are, but they are differences between people that are tied to sex hormones. So they also seem to impact how people process certain kinds of sensations, such as temperature and smell. They cause differences in skin texture. A host of other small changes, some of which we may not even know, but all of which have to be accounted for by the priors so that the interoceptive system, when it collects data on them, the brain can interpret that data correctly and only respond negatively when it is actually an incorrect, when something is actually wrong. So, meanwhile, we know from studies of childhood development that children begin to differentiate between themselves and others, and between different others at around the ages of 3 to 7. That's why a 2-year-old, if they're sitting right in front of the TV and blocking your view and you ask them to move, they might respond, "Why? I can see fine." And it's not just selfishness, it's that they literally do not understand that if they can see, that other people may not be able to, that other people are different in that way and may not be able to see what they can see. They begin at typically around the ages of 3 to 7 to begin to understand this and to learn how different people differ from themselves and from each other. This is also when children begin recognizing their own and others' gender. This is when children start being able to say, "I'm a boy, I'm a girl, that's a boy, that's a girl," and so forth. So the theory that ties this to body maps posits that what children are doing at this stage is in part integrating their perceptive systems. They're learning to tie together different sources of information, and among those, that is comparing what they gather from exteroception, especially vision, and comparing that obviously on a subconscious level, because body maps are not something that we're consciously aware of, but comparing that to their body map. And so one of the ways in which they start differentiating people is they separate people into those who resemble the child's body map and those who do not resemble the child's body map. And it does have to be the body map that the child is using, because that's what's in their brain. The interoceptive signals are coming in, but it's the body map that is actually what the brain uses as kind of the point of comparison. The child classifies themselves subconsciously as part of the group that they see as resembling their body map. And when they see differences in behavior between those who resemble them and those who don't, accurately or otherwise, when they see these differences in behavior, when they see differences in attitude, when they see differences in how members of these groups are treated by others, they internalize those differences. They come to expect the behavior of them, they come to expect of themselves the behavior that they see as being typical of the people that they see as resembling them, and they come to expect to be treated in the ways that they see as typical of the people that resemble them. And the theory goes that this combination of body map, differentiation, identification, and internalized behavior then becomes the core gender. There is then a second wave of this process during puberty and adolescence, because the body map has to kind of turn on a whole bunch of new priors as the body starts to change in puberty, and that in turn causes kind of a second wave of this process of determining identity. It is worth noting, my professor pointed out when I was giving this presentation, that this actually is not too different from current theories of how children develop a racial identity. So there's definitely some consistency across different aspects of how identity develops if this theory continues to hold as more data comes in and more research comes in. Now, in terms of gender dysphoria, what happens if there is a permanent incongruence between the body map and the signals arising from the interoceptive system? And we actually know of a case where this occurs. This is actually where the theory of body maps was first developed, was in studies of amputees and of a phenomenon known as phantom limb sensation. And what happens in phantom limb sensation is it is not uncommon for somebody who's had a limb amputated to feel unpleasant sensations in that limb, to feel discomfort or pain coming from the limb that isn't there. And the theory goes that it's because their body map has priors for that limb and is not receiving any information, which is a large discrepancy. So it handles it the way it always handles large discrepancies, which is to bring into conscious awareness a physical sensation that is unpleasant. And unfortunately, there's nothing, since the limb is just gone, there's nothing the person can really do to relieve that allostatic stress, and they have to find ways to cope with it. Now, what's really interesting, and I did not know about this until I read the Langer book, and he discussed some research on the topic, which I then went and looked at a little of. There's a phenomenon known of congenital phantom limb sensation. That is, there are cases of children born missing a limb who have phantom limb sensation in that limb. That is part of how we know that body maps are present from birth, because if the body map were in any sense learned, then the child would begin learning it without the limb present, and therefore not have any priors for that limb. But it appears to not be learned. It's something that's more, for lack of a better term, hardwired, or perhaps a better analogy would be firmware. And as a result, it is possible for children to have phantom limb sensation essentially from birth. So what about a child whose body map expects a different, quote-unquote, physical sex, who expects different primary sex characteristics? As discussed in the previous section, the formation of core gender follows your body map, not the interoceptive signals, because the interoceptive signals, again, are only processed by the brain when something is wrong. The brain doesn't, the portions of the brain that are developing your identity are much more recent, complex, advanced parts of the brain than the parts that handle that checking off the interoceptive checklist. They only hear about interoception when something is wrong, so the brain has to use the body map, not the interoceptive signals, to develop core gender. So you internalize the behavior and identity that aligns with your body map. While you are doing that, however, the people around you are perceiving your assigned gender at birth and behaving toward you in ways that accord with that, and expecting behavior from you that accords with that, and this generates a conflict. You've got two competing sets of expectations, your own and those of others. And that conflict generates stress and can and disrupts identity formation, and can honestly be quite traumatic for a small child who may or may not be able to consciously articulate what they're feeling. They may or may not be able to say, you keep saying I'm a boy, but I'm actually a girl. Some small children can, some can't. That's a lot to ask of a small child that has everybody around them saying, you're a boy, you're a boy, you're a boy. Both overtly and in subtler ways that the child is subconsciously aware of, like in how they're treated. Either way, there's the additional problem that they have this ongoing allostatic emotion and sensation. Their priors are getting in, their body map is receiving signals that do not match the priors and is responding with allostatic emotion and sensation, but nothing they do is changing the interoceptive signals to what the priors expect, just as with amputees. So they have to develop coping mechanisms, healthy or otherwise, to manage the stress that results from that, but they can't relieve the stress that results from that. It is always present. Then, at puberty, that stress increases dramatically as the body changes and the discrepancy becomes even greater. This explains a lot about gender dysphoria. Constant allostatic stress is the other stress we were missing when we were talking in the last part about minority stress as a possible explanation and saying that there needed to be something more. Adding allostatic stress on top of that may be that something more. So the vulnerability to trauma, anxiety, and depression is even greater than would be predicted by minority stress. In addition, it would explain potentially where the connection with autism lies. People with autistic spectrum disorder often have issues with their interoception as well, particularly where digestion is concerned, but it's possible that it would also extend to interoceptive issues with physical sex characteristics, and thus start in childhood the development of gender dysphoria. And finally, dissociation then becomes a protective mechanism. Disconnecting from the emotions disconnects you from those allostatic emotions that are unpleasant and never ending. It helps cope, not necessarily in a healthy way, but it helps cope with the frustration of constantly feeling this pressure to do something to feel better and not being able to find anything that works. It also explains another mysterious finding, which has been kind of anecdotally expressed for a long time. Research has confirmed it with trans men, but studies have not been done with other subgroups of the trans population. But it's been found that there are improvements with affect, that is emotion, from taking hormones, that those changes happen long before physical changes become perceptible. Typically, while there are internal chemical changes happening almost from the moment you start taking hormones, typically it takes a couple months minimum for physical changes to start being noticeable, and it takes years for them to kind of reach their final form. However, emotional improvement can start as early as 2 or 3 weeks into taking them. And the emotional improvement detected is noticeably greater than would be predicted by if it was just a placebo effect happening. And this would help explain why. Remember, the threshold for allostatic emotions is lower than the threshold for allostatic sensations. So the things that are causing the emotional distress are smaller discrepancies than the ones that are causing than the gross physical differences. Gross here in the sense of like large. So correspondingly, it takes less change to fix those than to fix the physical differences. The more apparent physical differences, the larger ones that are causing the allostatic sensation. So the emotional changes start happening earlier in the process when the changes involved are too small to detect consciously. Finally, this would explain why social transition can relieve what we've been talking about in terms of interoception. But again, the core gender is formed from a combination of internalized behaviors and perceptions and the body map. So the social transition can help with that internalized association of gendered behaviors with the body map. It can help with that conflict between, as a small child, what you felt and what the people around you expected. It can help kind of restore you to what you expected of yourself and help begin the process of resolving some of those issues and relieving some of those negative feelings which have become so tied in with the kind of physical issues of the body map interoception incongruence that they are kind of indistinguishable as sensations. And in fact, in some people, the differences may be purely, like if the discrepancies are small, then they may not need any physical changes at all. They may only need to achieve emotional changes, which can be done through the social transition. All right, kind of changing from the theoretical back to the more pragmatic. Is the core question, should it be in the DSM? Should gender dysphoria be a diagnosis in the DSM? So the primary argument in favor of keeping it in the DSM has to do with gatekeeping. Specifically, it has to do with the fact that for many trans people, possibly most, hormonal and surgical interventions, medical interventions, are significant quality of life improvements and may be necessary to relieve actual gender dysphoria as opposed to what the DSM describes as gender dysphoria. However, in order to access them, you need insurance, and you need to get that, and to get insurance to pay for it, you need a diagnosis. So there has to be a diagnosis that can be applied. In addition, many jurisdictions, following the models originated by Harry Benjamin, require diagnosis and treatment to legally recognize you as your gender. To use my own experience as an example, in DC, where I was living at the time that I legally changed my name and gender, the process for changing my name was exactly the same as it was for anyone else who wanted to change their name, which was I had to contact my creditors and provide proof that I had done so to show that I wasn't changing my name to escape a debt or commit fraud. And once a judge was satisfied that I wasn't committing a fraud, they ordered my name to be changed in the records. Changing my gender consists of then taking that order to the DMV and filling out the form to get an ID and checking whatever box I wanted for gender, because in DC you can check whatever box you want for gender and that's your legal gender. However, my birth certificate was issued by the US Department of State for reasons, and as a result, I had to follow their rules to change it. And their rules required a very precisely worded letter from a medical doctor. Somebody with a doctorate in psychology would not count, nor would a social worker who working as a therapist who typically would have a master's degree, or a nurse practitioner or anything like that. It had to be somebody with an MD. Writing a very specifically worded letter specifying that they had diagnosed me with gender dysphoria, and that my transition was treatment for that gender dysphoria, and only then would they update my birth certificate and my social security information. That kind of jumping through hoops is often what is required, and to make it possible, there has to be a diagnosis that doctors can give. In addition, gender dysphoria is a distinct and definable pattern of emotional and cognitive symptoms. It occurs only in trans people. It is not identical to being trans, the way it's currently worded in the DSM, but we can identify we can make a start at identifying some symptoms of it, and further research could, identify sufficient criteria to make it a DSM diagnosis. But some examples of symptoms of it are intense distress triggered by the experience of not being recognized as one's core gender or the thought of not being recognized as one's core gender, dissociation, self-disgust and self-hatred, anxiety about one's gender performance. These are all common things that will be recognizable to anyone who's been gender dysphoric as being elements of gender dysphoria. I'm sure that in discussion with a lot of trans people and a lot of research, we could find a detailed list, boil it down into a few criteria, and make a clear diagnosis out of it. The problem is, those first two things under the gatekeeping. There are people who need those things and therefore need a diagnosis who do not actually have gender dysphoria. They're just trans with no dysphoria. All right, what are the arguments for getting it out of the DSM? The first is that it pathologizes trans people. As I keep saying, the symptoms listed are not dysphoria. They're just being trans. Being trans is still being presented as in itself a disorder, even though there is no basis to do so. Because being trans does not in itself cause clinically significant distress or involve clinically significant impairment of functioning. It is only either having to deal with a transphobic world or having gender dysphoria, which is a distinct set of symptoms separate from being trans or subordinate to being trans, that it becomes clinically significant. In addition, many relics of old diagnoses dating back all the way to the DSM-3 and frankly back to Harry Benjamin are still in there. Things like the fact that it still uses language that assumes people are their gender assigned at birth. The fact that it mentions autogynephilia, which is a thoroughly discredited theory, part of the general class of theories that tried to make being trans out to be a sex thing. In this case, that it was essentially a kind of fetish. And the discussion of transvestic disorder, which again, there is no reason to relate that to being trans at all. Cross-dressing and being trans are unrelated. It's pretty much just there for the insurance is also a reason to remove it. It's not a real disorder. It's something that's there to convince insurance companies to pay for a needed procedure. That was the conclusion that at least one of the studies I read for this presentation came to, was that was literally all it was for. And some of the evidence pointed out that it is just there for the insurance. The presence of the post-transition specifier is basically saying, yes, this person has already been treated, their gender dysphoria is finished, but we still need to keep giving them hormones for the rest of their life, because that's true, you do need to take the hormones for the rest of your life, or else the effects start reversing, and that's unpleasant. In women, that effect is known as menopause, which, I mean, there are some trans people who do stop taking their hormones, trans women specifically, who stop taking their hormones deliberately in order to experience menopause. But on the other hand, there are also a lot of cis women who start taking the exact same hormones in order to avoid experiencing menopause, because menopause is not pleasant. Regardless, the post-transition specifier is basically there so that you can keep prescribing the hormones as long as the person needs them, even after they've transitioned as much as they can transition and their dysphoria has hopefully improved and is no longer an issue. There's also the note that it may not involve distress. Distress is a criterion, yet it also says that it's not necessarily present. So it's both required and not required, because it's not a disorder if distress isn't present. But again, there exist people for whom transition represents a substantial quality of life improvement, but who are not actually dysphoric. And so those people need, this diagnosis exists for them, who don't have distress. Finally, a reason to remove it is the treatment. Relief of the distress from dysphoria comes from lifestyle changes and non-psychiatric medical interventions. It's treated like an organic disorder, not a psychiatric one. The treatment would tend to imply that it is a physical disorder that has some psychological symptoms, and there are other disorders like that. Thyroid disease has psychiatric symptoms, but is actually a non-psychiatric medical disorder. So the argument is, based on how it's treated, that that's what gender dysphoria is as well. So what can we do about this? Well, the best case scenario is remove gender dysphoria from the DSM and eliminate the gatekeeping of treatment. Just make treatment available to people on an informed consent basis with no obstacles to getting it if they decide that it is the best thing for them. And to achieve that, all we have to do is get rid of insurance companies, get rid of capitalism, probably get rid of money, and get rid of all the cis-heteronormative stigma in our society. So basically achieving fully automated luxury gay space communism. That's not happening anytime in the near future. So what are some more realistic possibilities of what we could do? Well, you could move it to the organic disorders based on the treatment. The issue there is that, frankly, medical doctors are even more likely than psychologists and social workers to say, well, the physical features I'm seeing are male, so I'm going to talk about you as a male and treat you as a male, no matter how much you say that you're a woman. Or reverse that, or put in any non-binary gender. The point is that you're going to get even more biological essentialism, and as a result, even more gatekeeping from MDs than currently you get from psychologists and social workers, who are the primary people that work with the DSM. You could remove gender dysphoria from the DSM, but not move it to the organic disorders. What you do instead is you make gender incongruence or gender dysphoria a specifier in depressive, anxiety, dissociative, and trauma disorders. So, for example, you could say that somebody has depersonalization, derealization disorder with gender incongruence, or they have major depressive disorder with gender incongruence. And the idea is that then the treatment for that would be transition. The problem is that you're risking insurance companies insisting, oh, this person has depressive disorder, that will pay for antidepressants. We're not going to pay for gender transition treatments, only antidepressants, because that's what treats depression. You're also losing anybody who has gender dysphoria but not its comorbid conditions, and anybody who is trans and doesn't have gender dysphoria is not going to be able to get treatment under this. You could, and I just want to throw out there, like, people sometimes question, like, well, but if they don't have a disorder, what's there to treat? And the thing is, we do, in fact, do insurance-covered procedures that aren't for specific disorders. There's preventative treatment. There's things like physical therapy, which is for a wide range of disorders. Insurance companies will often have quote-unquote wellness programs that are tailored to your particular, may or may not, depending on the insurance company, be tailored to your particular lifestyle and presumed needs, but are not a treatment for a specific disorder. So it's not like it's without precedent for there to be interventions that aren't tied to a specific disorder, but instead tied to an improvement of quality of life, at least in theory. I'm a little bit skeptical about wellness programs in general. Since as with everything else insurance companies do, they're less about helping you and more about saving the insurance company money. You could make the diagnosis, you could have a diagnosis called gender incongruence. You could eliminate all that language that treats people as their assigned gender at birth, rewrite it to treat people as their core gender, include as specifiers with or without gender dysphoria. And then for the with gender dysphoria specifier, you could have the symptoms of actual gender dysphoria, while the symptoms for gender incongruence would be the description of being trans, that is what the current gender dysphoria diagnosis essentially is. This would improve empirical accuracy and enable research to be a little bit clearer about whether they're studying people with gender dysphoria or trans people or both or what. But it doesn't really help very much with the pathologization. It helps a little in the sense of, recognizing trans people as our actual genders as opposed to judging us purely on presence or absence of a penis when we were 5 seconds old. But it still is treating being trans as a disorder in itself, which is obviously problematic. Quite simply, there is no good answer, but I think at minimum what we do need to do is in the next update of the DSM, rewrite that section to clarify that either refer to people by their assigned gender at birth and clarify that you're saying assigned gender at birth with language like AMAB, AFAB, or refer to people as their gender. So instead of having one of the criteria being dresses, or cross-gender play in children, cross-gender toy preferences in children. You instead say toy preferences consistent with the stereotypical preferences of the expressed gender, or the experienced gender, as opposed to the assigned gender. That kind of thing. Instead of saying, playing with the other gender's toys. That would help. It's not a perfect fix. Nothing on here is really a perfect fix, except, destroying insurance companies and ending capitalism. But that would fix a lot of other things, but it's also not happening anytime soon. Here's the first half of my references. These are the books, websites, and journal articles that I consulted, or at least A through K of those. And then here's the second half, and the first one on there is the Langer book. Again, I really recommend this book if you're interested in kind of the theoretical stuff I talked about today, or if you're interested in just working clinically with trans people. I think it provides some very good perspectives for that in its later chapters, and a really good, albeit very dense, theoretical model in its first couple of chapters. That is the presentation. Thank you for watching. It is like probably 2 in the morning at this point. I can't see a clock because I have this full screen, but I'm guessing that's about what it is, so I'm getting pretty tired. So I'm just going to say goodnight here. Please feel free to comment with any questions as long as they are respectful and not transphobic. And I will do my best to answer them. Bye!